And so that's where I'm going to switch to talking about the antibody drug conjugates. We've had a handful of these around for many, many years. However, the number that is getting approved more recently is growing, and it's because the way that these drugs work is really exciting. So the antibody drug conjugate kind of treatment includes three different parts. The drug itself includes an antibody, a linker, and a drug. And so you can see here's the antibody that is going to bind to the cancer cell, the chemotherapy molecule, and then this linker protein. And so you need all three of these parts to have a successful antibody drug conjugate. The antibody itself must target a cancer-specific receptor that's limited elsewhere in the body. The drug that is attached to this antibody must be highly potent with a cytotoxic mechanism of action. We want it, when it gets dropped into that cancer cell, to kill the cancer cells, so killing the fast-growing cells. And really, really important, and one of the things that probably is, when you look at these, the least exciting from when we think about what the drugs are targeting, but the thing that made them successful and to be able to come into our reality is finding the right linker that is linking this antibody to the drug. The linker must be stable in the plasma, so when we give the drug, to keep the drug intact and inactive, but then once the drug binds to the cancer cell, the linker has to release the drug. So I've always kind of said these are a little bit like smart bombs, where the antibody is going to hone in on the target, and then it's going to get pulled into the cancer cell, and then the linker will come apart and the drug will be released into the cancer cell. And that's kind of what you see down here. So the antibody drug conjugate is going to bind to the cancer cell because of that antibody on the outside. It's then going to get engulfed and sucked up into that cancer cell, and this linker is going to break, and then the cytotoxic drug is going to get released into the cancer cell. So actually they are kind of resurrecting some of these old cytotoxic drugs that were too toxic just to give IV to people, but that are working really well with this because we're limiting the toxicity more to the inside of the cell. These drugs still do have toxicities, but they are different than if you just gave this cytotoxic drug. And so I'm going to give you the two examples of Tisotumab Vedotin, which targets tissue factor, and Trastuzumab deruxtecan that targets HER2. Starting with Tisotumab Vedotin, and just to kind of go through what it is. So the antibody part, the Tisotumab, is a humanized anti-tissue factor monoclonal antibody. The drug payload is something called MMAE, monomethyl auristatin E. It is a microtubule disruptor, so good for as cells are growing, you want to prevent them, hit the fast-growing cells and destroy them. And then the linker is the valine citrulline peptide linker, which all you need to know is that it is a good linker at delivering the tisotumab to the cells that are expressing tissue factor and then releasing that payload into them. So tissue factor is involved in a lot of our blood clotting, and in the heme world, we talk about it a lot. Tissue factor, the exposure of tissue factor is what can start a clotting cascade. However, it is highly expressed on cervical cancer cells across different histologies, but not as much on healthy cervical cells. So kind of exactly what we want with a good antibody, where it's targeting something cancer specific that is limited elsewhere in the body if we inhibited it. Oops. Tissue factor expression can affect proliferation of these cells and then invasion of the cancer cells. And so tisotumab was initially assessed as part of the INOVA TV 204 trial. This was a phase 2 single-arm study in 101 patients who had recurrent or metastatic cervical cancer who progressed after prior chemotherapy with or without bevacizumab. So you see how we're still building on, that was the backbone that, again, patients would typically receive. Tisotumab is an IV drug. The primary endpoint for this phase 2 single-arm study was overall response rate, and the overall response rate was 24%. However, this included 7 patients with a complete response and 17 patients with a partial response. So ultimately, the drug was granted accelerated FDA approval for patients with recurrent metastatic cervical cancer who progressed on prior chemotherapy, and that was in 2021. Now, since we had the single-arm study, the next thing to do is to compare it with the other standards of care. And so that is what was assessed in the INOVA-TV 305 trial. This was a phase 3 open label study in 502 patients, same population as before, and tisotumab was compared with standard chemotherapy, so a different regimen than what patients received before, but a variety of different single agents were utilized in this clinical trial. And they included topotecan, vinorelbine, gemcitabine, irinotecan, or pemetrexed. The primary endpoint, because this is a phase 3 trial, was overall survival. And so the overall survival favored tisotumab 11.5 months compared to 9.5 months with the chemotherapy, and this was statistically significant. Based on this, tisotumab then approved full kind of traditional FDA approval for the same indication in April of 2024. So it is now a treatment option in the advanced setting for patients with cervical cancer who have progressed on a prior therapy. One thing that I did want to discuss with tisotumab vedotin is that a unique toxicity with it is that it does cause some eye toxicity. In the INOVA-TV 301 trial, any grade eye toxic events, ocular events, occurred in about half of patients who were receiving the drug, with about 4% of patients having the more severe grade 3 or higher toxicities. Because of this, we can do a lot to help to prevent and to treat the eye toxicity. And so there are several things that are recommended by the manufacturer for people who are getting tisotumab vedotin. Eye exams must occur prior to starting the drug, and then prior to every cycle for the first 9 cycles, and then clinically as needed. Additionally, working closely with an ophthalmologist, prevention and treatment can be given, including corticosteroid eye drops, vasoconstrictor eye drops. These are recommended immediately prior to the infusion, and then cold packs are often used during treatment and then after the eye drops to keep the eyes cool. Lubricating eye drops can be used throughout therapy and for 30 days after the last dose. And then doing things to avoid additional irritation, like avoiding contact lenses, can also be recommended. So again, we recognize that these drugs do unfortunately come with toxicities. However, a big part of what we can do is to try to anticipate the toxicities, educate people about the toxicities, and do everything we can to try to decrease the impact on quality of life by doing things like using these different eye drops.